right here. And he sent in the best bio we've gotten so far because it was just refreshing. It's not who he is as a person and a little bit of his medical background. So he grew up in Los Angeles and came out to the frigid East Coast to attend Yale University. Then attended the University of Chicago for medical school, and then escaped the cold winters and went back to the University of Southern California for residency. After residency, he migrated back to the East Coast for family reasons and worked as a hospitalist in Stamford, Connecticut. Then he decided he missed teaching, and 3 years ago moved into academia here at Mount Sinai in the Division of Hospital Medicine. Dr. Chang has run the medical consult service and the pre-op clinic for the last 2 years, and just recently took over for Dr. Gliato as the co-director of the Medicine-Geriatrics Clerkship. Dr. Micah Mann, who's right here, is the first and only hospitalist fellow here at Mount Sinai in the Department of Medicine, or in the Division of Hospitalist Medicine from the Department of Medicine. He did his residency here at Mount Sinai, and he is from a nice warm place, Arizona, and went to University of Arizona Medical School and did his undergraduate at Northern Arizona University. Dr. Christopher Smith, next to Dr. Mann, graduated from BU School of Medicine and has a master's in health policy from the Kennedy School of Government at Harvard University. He was a resident and then chief resident at Mount Sinai Hospital. He's currently an assistant professor in the Division of General Internal Medicine, as well as the assistant program director for quality. Clinically, he takes care of patients at the visiting doctor's program, where he also conducts clinical research investigating primary care for the frail elderly. Dr. Smith has been engaged in a number of quality improvement efforts through his various roles in the residency program, and another of his research interests is working with residents to simultaneously improve their education and the care that they provide for patients, which is a nice introduction for the title of their talk, which was Ready for the Show, Using Standardized Patients to Assess PGY1 Preparedness to Deliver High-Quality Care. Dr. Smith.
So I have to stand behind this so everyone can hear?
And so that we can audience.
Okay. So I thought that I would try and bridge the generational divide by using a cultural reference, but my cultural reference is Ready for the Show. And so for those of you who like baseball and watched Bull Durham back in the late 80s, the show was what Kevin Costner was always talking to. Kevin Costner here, also known as Crash, and this is Nuke LaLoosh or Tim Robbins. They're always talking about being ready for the show, and in many ways that's sort of how I viewed the incoming interns. Were they ready for the show? And this is the chief resident here, yelling at the intern, you're not ready for the show, you're not delivering high quality care. So I thought this was a good analogy to two things, but then I realized that unlike baseball, where you can kind of hang out in the minor leagues for your entire life and then retire, in medicine, you get put up into the big leagues whether you're ready or not. So I think really being a chief resident is more like when my daughter is playing hide and seek and she yells out, "Ready or not, here I come." And so in that regard, we wanted to make sure that our residents were actually ready to deliver the care that we had hoped they would deliver. And so we're going to talk about an initiative that took place, that was built last year, put in place these last 7 or 8 months, and we're going to talk about the findings. And so the objectives of this presentation are to identify several key resident and patient interactions which can impact patient satisfaction and safety, identify the systems issues which prevent our residents from executing these interactions at a high level. Then we're going to critique our resident performance in the residents here in our consortium, in their performance of a discharge discussion through the use of a standardized patient. We're going to talk about which groups lag in their performance, and then how we are going to use standardized patients for next steps to improve workarounds. So a little bit of background. Regular and clear communication leads to improved patient satisfaction. There's a lot of studies that show that. There's a lot of studies that show that when we don't communicate clearly with our patients, they don't know what's going on, they're not satisfied with their care. And there's a really good body of literature that talks about communication in the setting of a discharge encounter. And so if providers, whether it's residents, physicians, NPs, do a better job of spending time with patients, spending more time discussing medications. You can decrease medication confusion, you can decrease readmissions, and you can improve satisfaction. And then there's a small number of studies that have shown that residents who do this well, patients feel better prepared to leave the hospital. Patients feel better prepared feel better satisfied with their hospital stay. But we're in this era where a lot of patients, if you read through the literature, think that their doctors don't really talk to them anymore, as you can see from this cartoon, and that even when they do, it's not helpful. And so here you've got a doctor saying, you suffered a contusion of the soft tissue below the fourth thoracic vertebrae, exacerbating the proximal sternum, which is a translation of, you have a bruised rib. And this sort of communication failure was actually something that we saw in our residency program. So during our chief year, several of the chiefs and I, we spent a lot of time doing very structured observations of our residents during morning work rounds. And we wanted to see, are they talking to their patients? Are they actually communicating what's going to happen during the day? Are they taking care of their pain? Are they even just being friendly? And what you see here, let me just walk you through this slide, is a lot of red being bad, green being good, and yellow being mediocre. So when you look at the green, the one thing we do tend to do as residents, we greeted patients in a friendly, courteous manner. So that was good. We always did that. And then it really kind of fell off from there. So did the residents introduce themselves by name and introduce the members of the care team that were sitting around the bed staring down at the patient? And what we found was that only 51% of our residents did that all of the time. Did they inquire whether the patient had any pain? Only 26% of our residents did that all the time. At the end of the encounter, as they were leaving the room, did they ask the patient, is there anything else I can do for you today? 23%, and so on. In terms of anticipatory guidance, really pretty lousy scores. Did they tell the patients, what was going to happen today? And we see that only 22% of the time our residents did that with all the patients they saw. Did they tell them the test results from the prior day? 39%, and so on. And then when we look at some harder outcomes, we see that maybe this is showing up in the quality of the care that we provide. This is the rate of readmission for pneumonia patients, and this is off of the Medicare Hospital Compare. And what you see here, this is New York Presby, this is Mount Sinai, and this is Lenox Hill Hospital. And red is bad, again, and so this shows that we are below the national average. So the national average is right around here, which would be somewhere around 18.3%. New York Presby and Lenox Hill are within the average, and we're worse than the national average in terms of readmissions. And just so people understand what that means, to be worse than the national average, that's not like, well, we were close and we just missed. Worse than the national average means you're in the bottom 5th percentile, below the bottom 5th percentile. Same for heart failure. To be at 29.8 when the rest is at 24.7 puts us in distinguished company to be both worse than the national average in both pneumonia and heart failure and MI, actually. We're one of the few institutions in the country that has garnered the trifecta of worse than the national average for all three conditions. Yeah.
I'm not trying to explain that away. I really am scared about it.
Yeah.
Is that sort of controlled for in any way by the demographic as far as the severity of illness or the degree of complexity?
It is very much controlled. And I can send you a link to the algorithm. But the algorithm for the readmissions is very complex, which is to say that they risk adjust for age, they risk adjust for gender, they risk adjust for all your medical comorbidities. So it is not just a unadjusted rate. And
discharged with heart failure, you readmitted when you got hit by a truck, you're still readmitted.
Right.
You still fall into that category.
If you're hit by a truck within 30 days, yes, you are still. But I would argue that that's probably not what's happening here. But all it does is suggest that, based on our observations about our residents and our observations about some hard outcomes, we have work to do. And so our chief residents, along with the folks at the Morshan Center, along with Dennis and Micah, we basically were kind of brainstorming. So what can we do? We can do a noon conference to help people do better with discharge discussions and with some of these issues. But we felt like we needed to do multiple different interventions. And so first we kind of asked ourselves a little bit of why is this happening? Why are we failing to communicate? And one of the things I think we all need to be cognizant of or recognize is the barriers that handoffs really are introducing into the care that we provide. This is the Department of Medicine inpatient coverage. I'm putting this up. This is going to be what's going to be rolled out in July. And so if you guys can decipher that, that's impressive. But basically what you see here is that you have, in just this one care area, you're going to have one resident and two intern teams. You're going to have night coverage with one resident and two interns. Sometimes you're going to have PAs. You're going to have folks on at night who are the teaching resident who might admit the patient. And so all of these things mean that over the course of a 5-day admission, you may have 6 residents who are your doctors or 7 residents who are your doctors, not including the PA, the NP, the RN, the BA. So definitely this is a barrier to effective and smooth communication. I mean, I would argue, I'm a big quality improvement person. I really think that we could do a lot better, but I also think that quality improvement is a double-edged sword. And quality improvement is when we make a statement that it's a systems problem, we diffuse the responsibility away from the individual. And so we now don't really know who's doing what. And that I think is a particularly important thing when it comes to discharging patients. And here's some of the paperwork that gets generated when a patient with heart failure, here's the heart failure discharge instructions, gets discharged. Now this is completed by a nurse. This one was completed by a nurse. This was completed by both a physician, a PA, and a nurse. And so it sort of begs the question, who's actually in charge of the discharge? Do the residents actually, or the attendings for that matter, ever actually go through this? Or do they just say, well, the nurse is going to fill out this piece of paperwork, and so they're going to be adequately counseled and discharged? And then there's obviously a change in the nature of our patients. This is just from a recent study in JAMA that looked at heart failure patients and the length of stay. So just so everybody understands, this length of stay difference means that from 1993 to 2006, heart failure patients were in the hospital about 30% less long. And this has real implications for how much time you have to talk to your patients. I remember my father talking about, his MI patients who were in the hospital for 8-10 days, and he could spend the last 3 days counseling them on what to do. And then this is also an indication that they're sicker. They're so sick they can't go home anymore, so they're all going to subacute rehab. So the complexity is different, the time you have with your patients is different. These are all the barriers to us doing our jobs well. So we moved to standardized patients because we thought it would be a great opportunity, because it's a particularly well-suited modality to assess communication skills. It can be used across residency programs. It's not used as well in graduate medical education, or it hasn't been reported as robustly in graduate medical education, but we have a lot of experience from undergraduate medical education. Any questions so far? Stop. Okay. So basically we partnered with the Morshan Center for Clinical Competence with Erica and Terry, and we said, why don't we do a discharge discussion case instead of some of the other cases about chest pain. We think this is where residents need to be trained, and this would really sort of interdigitate with a lot of the other things that are going on in the hospital. So we spent a lot of hours together building a case where we wanted to meet the following objectives. We wanted to ensure that the patient feels respected and understood, because we know from some literature that when patients feel respected, they feel that their encounter with the hospital system or with the outpatient clinic is more satisfactory. We wanted to make sure that we were using understandable language, no jargon. And then we really wanted to deconstruct the discharge encounter, the discharge discussion, into these discrete objectives. To review the patient's understanding of why they were there. Half of our patients get discharged home and they don't know why they were admitted. To explain the changes in their treatment plan. We wanted to make sure that our residents were advising on behavior changes to avoid future hospitalizations. We wanted to make sure everybody knew about their discharge appointments and tests, to discuss symptoms and signs that require medical attention, whether it's urgent care, your primary care, or the emergency room. And we wanted to ask the question of whether or not the patients actually understood it. So were the residents saying, do you understand? Were they saying, could you repeat that back to me? And then we wanted to assess the patient's ability to comply with the recommendations. So those are objectives. You have this in front of you. I'm not going to read it. That's why I gave you that handout. And that's basically the case. The case is a fairly straightforward 55-year-old man with stage 2 heart failure who comes in because his wife went out of town and he started eating Chinese food, and the next thing you know, he couldn't breathe. He came in, he was diuresed, he had a medication that was stopped, his Plavix, his Lasix was increased, the rest of his medications were the same. And like many patients, he had follow-up appointment, he had lab work that he needed to do in a week or two to assess the effects of his new medication regimen. So this is what you're looking at here is what the resident gets before they walk in the room. So they have 5 minutes, they read this case, they know what is going to happen next for this patient, and then we really wanted to stack the deck, and we didn't want anyone to be confused about what it is that we wanted them to do. Since this sort of use of an SP as an assessor of discharge discussion is something new to trainees. Trainees have been, going in and seeing whether or not the patient with a belly pain has an ulcer versus appendicitis, but not many programs were using this for this type of encounter. So we told them exactly what we wanted them to do. We want you to prepare the patient for a safe discharge home by providing a clear discharge plan, to explain the medications that will be continued, stopped, or modified, to discuss side effects, to review with the patient the outcome of the test completed during that hospitalization, to explain the signs of worsening of the medical condition, importance of keeping follow-up appointments and follow-up lab work, importance of adhering to a low-salt diet, and then we wanted you to assess the patient's understanding of our explanation. So we were really clear. This should not have been something that people didn't understand what we wanted out of them. And they should be pretty intuitive. If you're going to discharge a patient, these are the things that you would want them to know. Any questions about the case and the lead-up? I'm going to turn over to Micah. Micah is going to just talk a little bit about what we found, and important to that is going to be to understand how we deconstructed the interaction. To discuss with the patient, they had 15 minutes. So they had 5 minutes to read the case, 15 minutes to talk with the patient, and then 10 minutes to do a debriefing. Just to go forward. Okay.
Okay, thanks, Kris, and thanks everyone for coming. So as Kris mentioned, the specific objectives that we had for a discharge discussion with a heart failure patient were sort of deconstructed into specific behaviors. And if you turn over the page that you have with the heart failure case on it, we have all of those behaviors listed, and you'll notice that the bold corresponds to the sort of global behavior sort of category that we have up here. So for verbal communication, we expected them to greet the patient by name. We expected them to reintroduce themselves, and we expected them to explain the purpose of the encounter. I'm here to talk to you about your discharge. For nonverbal communication, we expected them to make an effort to appear unrushed, use appropriate body language to enhance communication, to make the patient feel respected, and to show empathy and to at least seem authentic while doing that. For facilitating patient understanding, we expected them to avoid medical jargon, and if they found themselves saying something that was jargony, to immediately define what that meant, to accurately summarize the information at the end of the encounter, and to encourage additional question or discussions. Basically to ask the patient, is there anything else that I can help you with? Is there anything that's unclear to you? For medication reconciliation, you can imagine, Kris mentioned, in this case, the Plavix was stopped, so we expected them to tell the patient the Plavix was stopped. The Lasix was increased to 60, we expected them to tell them that, and then also to mention the medications that were continued. For disease education, we expected them to just clarify that dietary indiscretion was the reason that they ended up in the hospital, to explain signs of worsening, reasons that they should come back into the hospital, such as lower extremity edema, or at least contact their doctor, or shortness of breath. and we expected them to explain the action plans for worsening, such as come back into the hospital. Follow-up, we expected them to remind the patient of appointments, to explain the need for follow-up tests, to provide information about the patient's diet, and to provide information about what activities the patient can resume. Finally, assessing barriers to discharge. This is sort of some of the social issues that I think that they should be anticipating, that they clarify the patient's ability to comply with diet. Can they get foods that are low in salt? Clarify ability to keep appointments, and verify the patient's ability to obtain medications in a timely fashion. So often we discharge patients, we expect them to get the medication, they end up back simply because they didn't end up getting the medication in a timely fashion. Okay, so with that, moving forward on figuring out whether or not residents are ready for the show. And just a brief note before I move on. So all these scores were either binary. They were either 0, the patient or the examinee didn't perform this task, or 1, they did. Or for some of them, it was not at all, inadequately, or adequately. So for some behaviors, such as explain purpose of the encounter. So they might just briefly say, I'm here to talk with you today, or something that's just, it's not inadequate. I'm here to discuss your discharge plan and to make sure that you're safe to go home and you understand what the follow-up is. So the way that we scored this in terms of the modes was, did they perform each of the behaviors listed there adequately, or did they perform the behavior? So each of those behaviors. And the reason that we did that was we didn't think that for 0, 1, and 2 that 2 was twice as good as 1, better than 0. We felt like residents should be performing them adequately, and it's not an overly high standard. And then it also allowed us to sort of group them in order to score residents. So how did they do? Or who are they, first of all? So in the Mount Sinai Consortium, there's of course Mount Sinai, there's the Bronx VA, there's Elmhurst Hospital out in Queens, so multiple teaching hospitals in Jersey, and then in 3 of the 5 boroughs, or actually 4 of the 5 boroughs. So out of a total of 38 possible programs that could have participated, 30 programs participated, so pretty good participation. And out of a total of 422 PGY1s in those programs that could have participated, we had 283 come through. 51% of the participants were women, 70% were in the 25 to 30 demographic, 64% were international medical graduates, and they came from a diverse training population. So 51% internal medicine, you can see a 13% pediatrics, 3% OBGYN, 3% family practice, 8% surgery, 10% emergency, and 13% preliminary or transitional programs. So you see that some of these are residencies that have a primary care component, and some of them don't. So surgeons are not generally as interested in primary care. Same thing with emergency medicine. So it's a very diverse group of doctors. Okay, so we broke down performance by individual domains, and you can see there's a range. On the right side, you can see a percentage for those performances, ranging from 93% for professional demeanor down to 14.1%. So it sounds like most residents greet the patient by name, they reintroduce themselves, and they explain the purpose of the encounter. Going down the line, very few are addressing these barriers to discharge. They're not asking questions to make sure that the patient's going to be able to get their medication, or ability to comply with diet. So in between, still not great performance on facilitating understanding, medication counseling, disease education. It's about a third of residents performed each of those behaviors adequately. Okay, so that's the global performance. We also wanted to look at whether or not there's a difference in terms of gender. Do women do better than men? Are they better communicators? Are international graduates better than U.S. graduates? And also, is there a difference between people who have graduated within the past 3 years or people who are a little bit further out? So looking at those results. So gender, you can see that again, it's not great performance, but it mirrors the global performance. It looks like there's a small difference in barriers to discharge plans. Not entirely clear if that's a real difference or if that occurred by chance, but there is a difference. When we looked at recent grads versus greater than 3 years since graduation, we divided it up into U.S. grads versus foreign grads. So there's really not much difference between those who graduated within the past 3 years and those who graduated further back. And same thing for U.S. grads. So this was for the foreign medical graduates, and this was for the U.S. graduates. Not much difference. So moving on to the one more. So prior standardized patient experience. You might assume that those who are familiar with sort of the format might do a little bit better, and there's really not much difference. Okay, so when we compared the U.S. grads to the international medical grads, there was a difference on 3 out of the 7 modes. So there was a difference in professional demeanor, and nonverbal professional demeanor facilitating understanding. So the U.S. grads were almost 100% in terms of professional demeanor and nonverbal professional demeanor. But again, nobody's performing well. Okay, so then based on sort of what I was saying earlier about primary care component versus no primary care component, we hypothesized that those who go into fields that are sort of more traditionally or at least have a primary care component might perform better. And so we divided it up into, let me go back to the other slide really quickly. So those with the primary care component were internal medicine, pediatrics, OBGYN, and family practice versus those not in a primary care, with no primary care component. And we did see a difference. Those with the primary care component performed better for facilitating understanding, medication counseling, and for follow-up. That 0.052 is not quite at the threshold. Okay. Any questions? Okay. So there was also a post-encounter survey just to assess how the residents felt about the encounter. Did they think it was valuable? And it actually provided good results. So to start, we asked their confidence with a general discharge discussion prior to the encounter. So it looks like about 55% were either competent or very competent coming into the encounter. But then they also felt like they actually improved their competence with the encounter. So about 60%, a little over 60%, had some increased confidence or significant increase in confidence. So that's encouraging. It sounds like they thought it was worthwhile. They also felt like it was realistic. About 80% rated it as either realistic or very realistic. And keep in mind, this also includes those who did not respond, which are 6.19% there. They also felt like it was valuable in their role as an intern. So about 3/4 thought it was either useful or incredibly useful. Finally, we asked them to assess whether or not they'd had previous or whether or not their previous exposure was adequate. And most of them felt like they'd had adequate previous exposure, but the data sort of suggests that they did not. The data, this is information that they needed to learn and had yet to really be confronted with. and then their level of interest in resources and feedback, greater than 3/4 are interested in learning more about this and focusing more on this. So I thought that was very encouraging. Even though maybe they're a little bit overconfident coming in, they feel like they have a lot to learn about this. So with that, I'm going to pass it over to Dennis Chang. All right, so I'm going to talk about one of the other cases that we did, trying to find, those resident-patient interactions that, residents go through that they need improvement on. So we tried to tackle workarounds. So this kind of grew out of patient satisfaction. So I'm sure a lot of you know patient satisfaction scores are a huge component of what's going forward in the hospital. Just to kind of review what it is, it comes from the HCAP survey, which is a hospital consumer assessment of healthcare providers and systems survey. Essentially, it was developed by Department of Health and Human Services, and it's really the first nationally standardized publicly reported survey of patients' perspective of their hospital stay. So it goes through a survey for the patients have a survey that they're sent. It's a randomly sampled survey of patients, and basically they go through, how did the doctors treat you, how did the nurses treat you, how was your entire stay at the hospital. So obviously we were kind of focused on the doctor's questions. So the doctor's questions are 3. So did the doctor explain things clearly? Did they listen carefully? Did they treat you with courtesy and respect? And so it's a multiple choice question, and they can either answer always, usually, sometimes, or never. And we really only get credit if they say always. So if you only usually did it, that doesn't really help the hospital that much. You have to do it always. So this is publicly reported. This is something you can get off the website. Any patient who has access to the internet, they can get this information. So you can see that when average for the whole hospitals in the entire country is 80%. And that means these 80% of the patients answered always to all 3 of the questions. You can see in New York it's a little lower. Maybe New Yorkers are just a little tougher, or maybe we're not as good. Hard to say. But you can see that compared to the other hospitals here, we're at 77%. So we're certainly a little better than the New York average, but we're below the national average. And this is important because a lot of reimbursement for the hospital is going to be tied into our patient satisfaction scores. And I'm sure that being below average is not going to cut it. Sure.
That's why average for all reporting hospitals, is that New York State or New York City?
This is New York State, I believe. Yeah, it's not New York City.
New York City as a group is lower than New York State.
Right. That's true. Yeah, that's true.
And that has been less so. I mean, back when Mark Chaffin was leading the charge against this survey as a concept, New York City was much worse. New York City has come closer to New York State over the intervening 4 years. So we're still in a tough crowd here in New York.
So, residents are a huge part of these HCAP scores, right? I mean, they take care of a significant number of patients here in the hospital. They are the people who spend the most time with the patients. So they're the ones doing the most interaction, the most communication. And part of this huge component of, residency in general are these workarounds. That's when the whole team sees the patient, and that's done every single day. So we tried to see, can we improve this, and also, so this was basically our goal. So basically we wanted to, one, educate the residents about the characteristics of a high-quality workaround. As Kris's slide before in the very beginning, you remember, a lot of it was red. They didn't do a lot of the things, anticipatory guidance. They weren't doing those things. So they obviously need some education. Also to kind of identify the characteristics of what affects the quality of these workarounds. So kind of the similar things we looked at for the discharge summary. 3, wanted to identify areas of the workarounds that are not performed well by residents. and also to assess the value of standardized patient encounters on resident confidence in these workarounds. So it kind of mirrored what we were doing with the discharge summary case. So here's the case. So we named it the Slater case, and I'll tell you why in a little bit. 55-year-old patient with hypertension, history of perforated appendix, stats-book appendectomy, coming in with a small bowel obstruction. So we picked small bowel obstruction because we felt that it was something that, from a knowledge base about the disease process, most students would know about, and whether you did surgery or OB-GYN or pediatrics or medicine, you'd have some familiarity with this subject. And the scenario is basically the residents are rounding on the first day after their admission. And patients later had several issues. So one is pain. So part of this was also to see how well they were assessing pain and how well they're doing with pain. The patient also needs a CT scan that wasn't done. So this is a very common scenario. I was told I was going to get a CT scan, but I didn't. Why is that? The patient also doesn't really understand their medical plan, which again is very common. And 4, the patient didn't know their test results or their diagnosis or what's happening with them. So just to kind of step aside, so the reason I called it the Slater case is I don't know if any of you surf. I would imagine no. But I used to surf a lot, and Kelly Slater is one of the best surfers who's ever lived, really. So you can see he's pretty good, right? That wave's pretty large, probably 20 feet. I've never done that. I kind of want to live till I'm older. You can see he takes a lot of chances as well. So, this is kind of an area that's never really been studied, and so we were kind of making things up as just generally what we thought was a high-quality workaround. So what we decided was a high-quality workaround was, they had to introduce themselves to the patient and introduce a team. We also decided that physicians need to kind of indicate what their role is. A lot of us come in, we just say, hey, we're Dr. Chang. They don't even know who we are. Are we medicine? Are we surgery? They have no idea. Also, obviously, you have to inquire about the patient's complaints and really discuss with them, are you having pain? What are you doing about that pain? And we really have to discuss what the results of anything that they've had done. And you also need to explain the overall medical plan. And you also need to kind of provide some anticipatory guidance about what's happening next. What's the next test you're going to get? How long is it going to take to get that test? How long are you going to be in the hospital? Are you going to be here 5 days, a week? All these things are very important to patients. And the last thing is obviously to facilitate any questions that they have. And patients vary whether they have a lot or a few. So we created a checklist similar to the one that we had for the discharge summary checklist. So verbal communication skills, nonverbal communication skills were very similar to the ones that you have on that sheet. But we added a couple, which is pain control, which is basically, did you ask about pain? Did you address it? What were you going to do about it? Disease education, kind of informing the patient about what a small bowel obstruction is and how do we know that? Why do we think that you have that? And then part of that disease education is kind of a results review. What exactly has been done and what is going to be done. And then anticipatory guidance, which is what is going to be done. So the next steps for us, we haven't really analyzed all the data from the Slater case. I think we're going to try to do similar to what we did with the discharge summary case. Something we learned from this is kind of revising some of the checklist items. Some of them were a little bit ambiguous, especially with the Slater case, since we didn't really have a lot of data or previous studies before to kind of back it up. And to be very specific about what we do. That's one thing we learned from this is that you can ask a question that seems good, but you have to have specific criteria about what gives somebody a point, because otherwise, it's kind of up to whoever the standardized patient is, whatever the situation is, and so that's not really good data. We also, although we were very specific with the discharge summary case, we were not that specific with the Slater case, so that's something that we need to revise and be very specific about what they need to accomplish. And the last thing is something that Terry's working very hard on, which is kind of improving consistency and accuracy of the standardized patient assessment. And the ultimate next step for all of this is we really want to develop educational programs to improve how students and residents do discharge summaries, do workarounds, communicate with patients, and ultimately, hopefully this improves patient care and their outcomes. So a special thanks to Erica and Terry, who obviously worked very hard with us on these cases. As Kris alluded to, we spent a lot of time together. And other people we wanted to thank were Dan, Lua, and Mark. Now who's not here anymore, and because Lua and Dan helped Kris with a lot of the kind of initial data gathering, and Deb Marin obviously for a lot of the patient satisfaction stuff. So I don't think Sarah's here anymore, right? Yeah. So well, Sarah did a lot of the data stuff, I think, in the beginning. So I just wanted to open it up for questions about any of this. Yeah. So
we haven't, and the reason we haven't is because it costs money to send them through. Whereas Intern, we can send through as part of the benefit of being part of the consortium. We certainly, when we were designing this, we had conversations like Andy Dunn, for example, about wouldn't this be a great way to assess your faculty, or even to assess new faculty as part of that first 6-month period where we're looking at the competencies of faculty. So it's an opportunity that's there, but no one's really been willing to take it.
And then on a gut feeling, the fact that you gave 15 minutes should register in your head. It's going to take me time to discharge a patient.
yeah.
I'm going to have to sit down for 15 minutes every time I discharge a patient. That's probably a subconscious learning experience.
Yeah, we reviewed some of the videos, and it's surprising. Some people just know that, and you see they spend all this time, they're answering all these questions, and then there's some people walk in and they say like a couple things, and then they walk out, and you wonder, what were you doing in there? What were you thinking? But it's amazing how varied people are as far as how they go about it. Yeah, go ahead.
Well, this didn't cost money because we did it with Kris and Dan explaining the gold standard clinic that's doing everything correctly. And when they got that as their post-encounter educational component, they got to watch it. And you'll be happy to know that they did it effortlessly. Only did like maybe 2 takes. And they both were great on camera, too.
I'm surprised that 76%, if I have the number correct, of the interns felt that they had had some education before on giving a discharge instruction. Anecdotally, I don't feel like I certainly never learned, when I was in my med school or residency, we talked about a discharge instruction. It was like, kind of insinuated, and of course you chat with the patient, of course we talked about, but the fact that there's this is the time where you sit down and you do all these things, that never was taught. So what's interesting is not only was this case something you were evaluating how they do it, but I almost feel like you're actually teaching them that this is something you have to do.
Yeah.
It's like 2 components.
Right. For this analysis, for what we want to do next, we felt it was really interesting to look at it this way. As what if people, you say, here's a patient, tell them how to get home, what do you actually do? And we learn that they're missing a lot of stuff. But there's another part to this in terms of we ask people for how they feel, whether they learned anything from the encounter. It's self-report, but they definitely feel like there was some improvement in their self-confidence through participation.
Yeah.
Well, I want to comment on that because I agree. I think number one, I think this is a great medical education program. That's spectacular. But I think this is a failing of the medical schools in the 4th year. And David and I have talked about this at length over the last several years. We and no other medical school really does a great job in the 4th year. It's a waste of time. These are the skills that should be taught to the medical students. And I'm surprised that they did as well as they did. To be very honest with you. I would have expected that all the results would be even lower.
But you also gave them a prompt a little bit.
Yeah.
These kind of things in the discussion.
Right.
Yeah.
That was the big debate, whether we tell them nothing and have them go in and see what their baseline is. But then we felt like if they all fail, then we'll tolerate it. We don't know where to set the bar. And so, at least for the first case, we actually did that concretely. We were hoping that this was a little bit more intuitive, and that, because the residents had been doing it, and a lot of them came through in the fall, so they had started residency in July, so hopefully they learned or someone had mirrored it. But we felt that this case was a little bit easier for them, hopefully. So it's hard the first time around to know what the level is of expectation and how much to put into it.
So, one gratuitous comment in the question. I know we're all looking at these outcome data of hospitals across the country. Every time I see it, I get more and more shocked. The average is that 1 out of 5 people with pneumonia come right back to the hospital, 1 out of 3. And that's kind of, okay, we're behind this stuff, I get it, but it's just stunning to me how bad this is. So the question I have, it's really interesting that you take something like the discharge plan and the communication or around and try to break it down into its components. What did you guys think about the idea that you had to somehow weave in empathy, compassion? Is it easy to stick as a separate category so that at one point in the discharge summary or in rounds you need to say something compassionate and empathetic to the patient, or is the expectation that it's kind of woven through in terms of breaking it down into its constituent parts? And the other similar question is, in particular on rounds, because of where we are, is there a teaching thing that fits in somewhere there? How to do a really good bedside round when you're seeing the patients in the morning? Are you including the expectation that at some point you turn to the student or the intern and do a little bit of clinical teaching, or is that not necessarily included in this?
So I can comment on this later. The workaround, that's not really included, the sort of teaching aspect of the workaround. It's purely focused on sort of like their teaching and interaction with the patient. Yeah. So yeah, that part is not included. Although it's interesting thing too. Yeah. 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 Right.
They might not ask about pain again.
Right.
So that, and that is a reality.
Yeah. I think that I sort of was conceptualizing when we were coming up with this. I don't know if I was kind of conceptualizing as the intern going in the morning and kind of pre-rounding almost. I don't know if you were thinking about it more, but that was kind of how I was conceptualizing, because it's a one-on-one interaction as opposed to like a 3-on-1 interaction.
I don't know, it's hard to say. I mean, a number of programs don't pre-round anymore because we just don't have time in the day to pre-round if we're going to meet our work hour regulations. So in some ways, I don't know that it matters so much, but I do think that the empathy part is a little bit different in the two cases. The Johnson case, there's not as much of an expectation. There's an expectation that they'll be respectful, right? But
I think Micah mentioned that you need to be genuine in the way you're expressing whatever it is you're saying to the patient.
Right. So for the Slater case, there's a piece of it that's sort of like you acknowledge that someone's in pain, and you acknowledge that you're going to do something about it, which is a little bit more empathy, and also a little bit more of what we think we know patients want when they're in pain. They want the doctor to acknowledge that they're in pain, not just to say, whining again. So I think that was built into that case a little bit more explicitly. Or it was built into the evaluation.
Yeah.
I think it's really impressive. I was such a nicely designed study and intervention. And so one of my questions around that, one of the things I really loved is that you created this post-encounter education, and that you showed them what it should look like. Took the opportunity and teach them about it. And so I was curious, what did that involve? Did it involve
I think, just to add to that, some of the data that was kind of interesting is they all thought that beforehand they were really good at it, that they knew what they were doing. So some of the difference that we were hoping you'd see after seeing the educational video wasn't there because they already thought they were good. So it's surprising, you know.
I'm sorry.
Yeah.
And I know that Chris knew about this, so maybe this is something else, but that happens a lot in teaching skills. That if you do a traditional pre-post, that sometimes the skills will actually go down because
Yeah.
they realize that they didn't do it. So there's an argument that you should do a retrospective pre-post and ask them how well could you have done this prior to this information, and then look at that difference.
That's a good idea, yeah.
So that's not, I don't think that anyone was, I think it's obvious actually when you look at the data that's what happened.
We thought we might show a difference between them self-reporting, but Eric suggested that we needed like a retrospective, and that's exactly what we're doing. I'm not a factor. But I want, and I'm not a Steinbrenner, but I want to analogy to baseball. We're just going to open tomorrow.
Yeah.
But we had spring training for like 3 months, 3 weeks, right? 4 weeks, maybe more than that. Do we have a pre-entry into residency training, spring training? So at least we all know that they've had a basic training and they're not learning on the fly.
Well, that's exactly the point I was making, so you don't have to.
Yeah.
As everybody in this room knows, I mean, the list of things that people would want us to teach in medical school and in residency is long and gets longer. And so how do we think that this is an important one that ought to rise above the noise of the other demands?
Let me tell you, whether we like it or not, it's essential. Otherwise, we talk about budget cuts. This is crucial. And I think the trouble is, you have enough data already to say to Mark, to say to Mike Robin, et cetera, this is now a policy. And we got to do something about it. There's an open 2 weeks prior, late June. As I say, I'm not a factor.
Yeah, well, and it's hard too. I mean, having been through the orientation, having had to leave the orientation, I can guarantee you that people learn nothing from that orientation. And it's not, and that's not to condemn anyone, except that it's just the wrong way to
Got to be a format.
But I do agree with you that this data is compelling enough that it should grab people's attention and say, wow, the thing that we're saying, go do it. They may not be ready to go and do it. And so how do we more mindfully?
Well, there are 2 places where it can be done.
Mm-hmm.
But it can be done in medical school before commencement, and the appropriate time to do it is after the match. And then everybody going into medicine gets a curriculum for 2 weeks. Everybody going into surgery gets their skills set for 2 weeks. Or it can be done during orientation at the institution. But that's a very expensive proposition to do that. See, we have a total of 1,000 residents from all these programs. We're going to bear the cost of that. And so,
when you do a cost analysis on it,
well, now, yes, because now it's going to cost
2013 is going to cost money.
Right.
Yeah.
Which is, why when we approached America, we thought this was such a great way of putting, more presented conversation, all of these issues right up front for everyone to see. So hopefully what we're going to do, some of the analysis is going to hopefully be more the medicine side, we keep track of readmission for all our residents. So next year we should have enough residents that have gone through the SC experience to be able to have a gradation of performers, and then we can sort of look and see, do the high performers actually have a better track record for readmission? And if we're able to show that, boy, that'd be a pretty powerful
you're right.
statement both on the
patients a year.
Yeah.
Same problem. Very, very isolated. They got about 5 issues.
We have to reanalyze. We can look at the data thoroughly. We have it.
They got 3
And
OTs.
I would argue that I actually think that this is one of those when do you do it, same thing like with the teaching course, that when do you do it before they're teaching, I think that really, even if you teach them in medical school, it absolutely must have reinforcement. Then when you get to the board, you're completely overwhelmed. Even with the best intentions, they're going to stop using the skills. And so it needs to be in the moment as well. After they've done it for a while, and then be presented with this outcome data. And
the literature, it is not accepted that the discharge discussion in full form is tried to evaluate it here. It's not really necessarily accepted that that's even the standard. You have to try to talk to medicine, we've talked about the different components, particularly group study a lot, but it's not clear that people think that this should be the model, that the doctor sit down for 20 minutes, 15 minutes with the patient and work through every single piece. And that's part of, I think, where quality improvement comes out. It's a little bit astray is that, doctors don't do it, nurses always do protocols. We give nurses the medication reconciliation. We give the PA make sure they have to follow appointments. And so I think we also need to first even just make a statement that this is the right way to do a good practice. And you can still have a PA do the